Well, again, thank you for a great introduction, and it's really, really a pleasure to be with you today to talk about something that really is an urgent matter. There is a lot of data that I could present to you, and I know you've probably seen a lot of that data around a lot of the prevalence, incidence, what's happening in America, and I will bring a little bit of that into our discussion today. But essentially, we have a major problem that if effective interventions and the right policies aren't put into place, it will bankrupt us. The cost of diabetes is significant, both financially and human. And what my role today is to talk to you a little bit about some of the solutions that we've seen implemented in other states, as well as some of the things that we know by research we need to start looking at. So I really hope that we can talk after I speak and after my colleagues that are going to be on the panel speak and have a discussion about some of the ways to think through this problem and how we can address it. I am a senior consultant with the National Association of Chronic Disease Directors. That's not a real sexy name, but nonetheless, we have a lot of work to do. And essentially what our role is to provide technical assistance and support to all state chronic disease programs. So if you're not familiar, which I'm certain most of you are, but if you're not, every state has a significant amount of funding that comes from the CDC that establishes specific chronic disease programs. And diabetes programs are in every single state, the Diabetes Prevention and Control Program. So my role as a consultant is to really help them to increase their capacity to address the problem and the burden of diabetes within the state and help them to implement effective strategies to do so. So that is what I do. I used to work in the state of Kansas. I was a chronic disease director in the state of Kansas for about 5 years, so I kind of can understand what's happening in the states pretty well. But now I get to work with all 50 states and 9 territories, so it's kind of fun and it's exciting for me. So again, this is on my organization. Again, just trying to work to help build capacity in the states to address issues of chronic disease and prevention and control. So today, what I want to talk to you about and really set the stage for our panel, or the rest of our panelists, is I really want to talk high level around the problem. I want to give you some examples of the solutions and opportunities, and then they will, again, like I had said, be talking more about operationalizing some of those solutions, and I really hope we can enter into a healthy dialogue about that. So, we do have a problem. I could sit here and give you lots and lots and lots of data about what's happening in each and every state. You have a lot of that information in your packet. I'm focusing on type 2 diabetes today. We know there are type 1 issues as well, and we'll be hearing a little bit about that in our panel presentation. But really, the majority of our cost drivers are with the majority of people with diabetes who have type 2. But we really do have a problem, and this illustrates it very well. We have 26 million people walking around with diabetes. Approximately 19 million of those are diagnosed, and the rest of them are walking around and don't know it. So those are the ones that we're really very concerned about. But we're very concerned about those who have diabetes. But what I really want to focus on are the 79 million people who are coming. That is the bottom of the iceberg there, and it really is going to bankrupt us if we don't do something from a prevention and actually the treatment side as well, if we don't really think about what our options are. So it's really quite significant when you think about it, and if you're interested to know about your own specific state data, I believe it's in your packet, and you can get some of those numbers. But quite honestly, every state is having issues with the problem of diabetes. It didn't used to be that way, but it's happening, and I'll talk a little bit more about some of that data in a minute. We know we have a problem with obesity. Obesity is a risk factor for type 2 diabetes. Not everybody who is classified as obese will develop type 2, but we know it's a risk factor, and we know that we have some serious issues with numbers of people who are in that category. When you think about the 79 million and you want to think about it in percentage, it's approximately 35% of the population. So unfortunately, many states don't collect data on the numbers of people with prediabetes, so they can only make their best educated guess, and it's approximately 35% of the population. But the issue is that generally less than 10% of the people who have prediabetes are aware of it. And prediabetes is not something to celebrate. In other words, if you go to the physician and they say, oh, don't worry, we did the screening and you have pre-diabetes, you don't have diabetes. We don't want people to walk away and say, oh, yes, I don't have type 2 diabetes, I only have pre-diabetes. It is something to celebrate a little bit, but they will eventually move into type 2 diabetes if they don't do something about it. So we'll talk a little bit about that. But it's really an important component to know that less than 10% of the people are aware that they are that at risk for type 2 diabetes. The other thing to mention is that we do see prevalence of diabetes increasing, and we'll talk a little bit about that in just a minute. But we know that 1 in 3 adults will have diabetes in 2050. That's what the CDC is predicting. We also know that Americans are living longer, so that's going to impact the numbers of people with diabetes. We know that we're doing a much better job of diagnosing people with diabetes now. We know that there are major increases in minority groups that are at high risk for type 2 diabetes. So a lot of these things are contributing to the numbers going up. But we have, the issue of about 1 in 10 in the U.S. now have diabetes, and that's just something that we're not going to be able to live with financially going forward. So a few facts. I'm not going to bore you with scientific data. I'm going to make it a little bit more relevant to your world. The number of Americans with diabetes has more than tripled in the past 2 decades. In fact, just last month, the CDC came out with a report that really did highlight the increases in prevalence from 1995 to 2010. And essentially what that report showed is that in 42 states, the prevalence of diabetes increased by 50%, and in 18 states, it increased by 100% or more. I hate to call out states, but I want to give you a little example here. In Oklahoma, for instance, it increased by 226%. In Kentucky, there's a lot of people in Kentucky here, it increased by 158%. In Georgia, in Georgia it was 145%. In Alabama, 140%. So, we're not going in the right direction. Any increase, even some like in New Jersey, for instance, was in the 80% increase. It's still increasing, it's still reaching a ton of people, and if we don't do something, if we don't provide effective interventions and policies, all rates will continue to increase, impacting our budgets and our quality of life. We know it costs a lot of money to care for people with diabetes. We know that it's significantly high from direct costs, but the indirect cost perspective is just astounding when you think about lost days of work, disability, those kinds of things, especially as people progress in the disease and complications occur. So we know it costs a lot of money. We know that diabetes is the leading cause of kidney failure, amputations, and new cases of blindness among adults in the U.S. I mean, this is the disease that is the #1 driver of those things. The good thing, though, is that we know that there is a way to prevent or delay type 2 diabetes, the onset of type 2 diabetes, and I'm going to talk to you a little bit about that could save a lot of money and prevent a lot of new cases of diabetes going forward. So that's all the data I'm going to show you. It's a problem. It's a big, big problem, and I bet everybody in this room has somebody they know that has diabetes. I mean, now you do. If you didn't, you do now because people said they have it. So, there are some significant things that you as a policymaker need to think about what your role could be to start addressing this issue. I like to look at the iceberg a little bit differently. I like to look at it where we're actually doing a fairly good job when we do recognize and diagnose people with diabetes. So the top of that iceberg really does represent people with diabetes complications and people with diagnosed diabetes. Those are the people that we know. What's happening below, again, I can't say it enough, are the undiagnosed, the people with pre-diabetes, and the people at risk for diabetes, okay? So it's pretty significant, and the only real way that I can sort of get my hands around it is to look at it this way. So that's sort of how I like to look at it. Solutions. What solutions are out there that might actually be helpful, that are actually playing out in other states? Let's talk a little bit more about what those solutions might be. I like to couch them in 3 different areas, so I'm going to present them in 3 different areas. The way that we have to look at diabetes is on a continuum, and I sort of toyed with putting a slide in there that is a little scientific, but does illustrate it's sort of the continuum, if you will, where you've got people with normal glycemic index or lab values on one end, all the way down to people with complications, and there are points of intervention along that continuum. And the one thing that we always think about with strategies to prevent or delay the onset of type 2 diabetes is when we intervene at one point on that continuum, it's going to prevent that person from continuing to move down the continuum. So we're going to couch it in a couple or 3 different areas: detection, prevention, and treatment. And I have some examples. They're really high level, and we can talk a little bit more about how they play out. But in each of these categories, I think this is really that continuum of intervention. So when we think about detection, we need to think about screening. We need to think about finding the people that are our targets. Screening really is the entry point to containing this epidemic. We have to be able to know who our people are that need interventions, that need specific areas of focus that we'll talk about in just a minute. So some of the things that we have seen as high importance that we're working with states on is really looking at the populations that they can actually address, the state legislature can actually address. So we think about the populations that they pay for. Typically it's the state employees through the health benefit plan, and it's the Medicaid population. So we recommend that that states screen state employees to prevent and detect diabetes. Now this is done in several different ways. I've seen it done through a mandatory health risk assessment with biometric screening so that they can actually find out who their people are. We've seen it done through specific physician agreements. There are other states who do it on a voluntary basis, so you're missing some people. But nonetheless, a screening program can actually identify who your high-risk people are and get them to where they need to go. The other role that really needs to be filled is your healthcare providers in your state, and really helping them to implement, carry out their role to screen and detect diabetes and pre-diabetes. This isn't always happening. Physicians are busy. They have a certain amount of time to see patients, and many times patients aren't being screened if they show risk factors. One of the things that we can engage the physician and healthcare community in is really fulfilling that role of identifying people with diabetes, but even more importantly, identifying people with pre-diabetes. That's intervention in that area would be really critical as we move forward, as you remember the bottom of that iceberg. And then a really important area that I think is highly neglected is the area of gestational diabetes. So we know that screening pregnant women for gestational diabetes is a standard of practice. Most of us would probably agree and believe that. And it's a reimbursable screening. However, we don't really know how often it's happening. It's not mandated. We don't know that women are being screened for gestational diabetes. And so one thing that we sort of put in the detection sort of policy solution is to screen in the Medicaid and state employee population at the appropriate time to find out if they have gestational. Because if you do have gestational diabetes, women who have that can go on to develop type 2 diabetes. They have a 35 to 60% chance, just because they have gestational diabetes, to developing type 2. It is a risk factor for type 2 diabetes. So it's important to identify this population, and this population sometimes falls through the cracks. So there's a significant amount of opportunity here to detect diabetes and pre-diabetes through gestational diabetes screening. Again, screening being the entry point, people who have prediabetes and people who have undiagnosed diabetes, if you don't screen, you're not going to know. And then the good news about screening is that we know how to treat people with diabetes, and we know what works to intervene with those who have prediabetes to prevent full-blown type 2 diabetes. So screening is part of the detection process, and it really is an important step in moving forward with addressing the problem. Prevention. We've been talking prevention for many, many, many years, and there have been many, many clinical trials that show what works. The diabetes prevention project, the clinical trials, the intervention that was studied for so long, demonstrated what works. We have the evidence, we know what works, and I'll talk about it in the next couple of slides, but prevention is the key to containing healthcare costs in the world of diabetes. So again, thinking about the 35% of the population that has prediabetes, they will develop type 2 diabetes if change isn't made in their lives. They will. So how do we prevent that? Well, one of the policy solutions is to provide coverage or health benefit coverage for the National Diabetes Prevention Program for state employees as a health benefit. You know, the CDC was authorized by Congress to oversee the National Diabetes Prevention Program, and there's a lot of movement right now in states to scale the delivery of the Diabetes Prevention Program. You may be familiar with the YMCAs program and the Y Diabetes Prevention Program. Many states have delivery sites in place. So having a mechanism to pay for that is really the way that we're going to get people to attend these classes, because this is where the evidence about lifestyle change is delivered. And the evidence shows that it really does work. And then also covering it for the Medicaid population. Now, we recognize that this is a time of tight budget constraints, but the funding mechanism or the delivery mechanism is quite inexpensive at this point, but based on some of the methodologies that are being implemented in states, and it does prevent people from moving into diabetes. So what does that look like? So pre-diabetes, intervening can make a difference. So essentially the Clinical Trial Diabetes Prevention Project research study asked the question, can type 2 diabetes be prevented or delayed through a lifestyle intervention or with metformin or medication in people with impaired glucose tolerance? So in other words, they don't have diabetes. Can a lifestyle change program prevent diabetes better than just giving them medication? So that was essentially the bottom, you know, kind of the premise for the project. And what they were looking at is they were looking at health outcomes through weight loss. So looking at 7% weight loss and 150 minutes of physical activity a week. Those were sort of the indicators for what they were looking for. And I want to direct you to that second bullet. The lifestyle group reduced risk of type 2 diabetes by 58%, and in the population that has more prevalence, the population over 60, it was actually 71%. And the medication group reduced it by 31%, so it's almost twice as much of a decrease of developing type 2 diabetes with the lifestyle group. And then following up for 10 years, it was still about twice as much from the lifestyle group preventing type 2 diabetes than the medication group. So we know that this program works, and there have been many studies done since the original diabetes prevention project through the clinical trials. There have been many real-world setting style research studies to show how this can be delivered in a community setting, and they have similar results. So what we really are advocating now is that legislators and that policymakers and decision makers get involved in the implementation of this program within your state. And there's lots and lots of activity happening right now in a variety of states. The benefits of that program, just so from a kind of a cost perspective, really is impressive. If you treat 100 high-risk adults, you can prevent 15 new cases of type 2 diabetes, prevent 162 missed work days, avoid medications, and it saves approximately $91,400 in healthcare costs. So we're seeing more and more of these studies being done, but this is several studies that do show that there are some significant benefits from a cost perspective of this program as it's being implemented currently. And I'll be happy to answer more questions about that when we're done here. So I talked about detection, I talked about prevention, and now I think the next step is the treatment side. So treatment is vital to managing the impact of diabetes on the state health programs. If you look at the data through the Medicaid program or through your state employee health plan, you will find that some of your highest cost drivers are people with diabetes and the management of their care. In the treatment area, when we're talking about solutions, a lot of that has to do with coordinating the data so you can get a true understanding of the reach and scope of the disease. Currently, many of that data are separate and housed by separate agencies, and agencies don't quite collaborate with one another to really get a full, true reach and scope of what it is they're actually doing. So one of the solutions there is to really work at coordinating that data collection and making sure that there is a real true understanding of the issues. And then upon coordinating that data collection, then developing a plan of action for recommending evidence-based practice implementation. So getting a real good lay of the land around treatment and then developing some evidence-based practices. So when we think about improving quality of care, some of the things that your state programs are focused on, some of the strategies that your state programs are focused on, is helping with within healthcare organizations to implement health system changes that can actually improve the quality of care for people with diabetes. And you know, that's not happening sort of at a statewide level. It may be working with health systems on a separate health system by health system perspective. But nonetheless, quality care improvements for people with diabetes, we know when quality of care is improved, we know that costs go down. Some of the implementation or maintenance of those evidence-based reimbursement strategies also are very, very helpful. So looking at patient insurance co-payments, and a lot of this is being done in the private sector when they're looking at value-based benefit design and tiered medications and such. Looking at public insurance reimbursement for medications and testing supplies. Some of those things that's happening in the private sector really is not crossing over so much into the Medicaid population or into some of the state employee benefits health plans. So, the other area that is really helpful when we talk about treatment and we talk about quality of care and management and decreasing the complications of diabetes is to offer self-management education. This is an evidence-based intervention as well that's been studied extensively. And when people have access to recognized self-management programs, they do better in their own management of their disease. So ensuring that there's sustainability or reimbursement for these diabetes self-management education programs. I don't have the number off the top of my head, but there's only about, I think it's a little bit less than half of the states actually have diabetes self-management education reimbursement through their Medicaid benefits plans. So we know that it really does empower people to manage their own care and that it is an evidence-based intervention. The other thing that I want to bring up that's happening around the country is looking at solutions that really do change scopes of work for pharmacists and community health workers, and that we can actually engage allied health professionals in this arena, that they can assist with self-management education delivery, and that they actually have some sustainability and some sort of way to get reimbursed for that, so that there's a broader opportunity for reach when you engage other allied health professionals. So I want to just say then, as we get close to getting our panel here and maybe talking about asking some questions, is one of the things that all of these things is sort of drive to is, leads to, I guess I should say, is the need for breaking down silos and coordinating this activity in a state. What I find when I work with states is that state agencies work in silos. I'm sure you all probably know that. My experience is that if one agency could just talk to the other agency and work together on a strategy that really, they share the same target population, they would just kind of enhance their work much, much more effectively. So what we see playing out right now in several states that is really being very well received by many state health departments and also CDC is what we call the Diabetes Action Plan legislation, and there are several states experiencing this right now. Essentially, what that really does aim to do is it aims to provide a collaborative framework for coordination around developing a plan for how your state should tackle this epidemic. Until that is a coordinated effort, you won't see much movement or you won't see much change because, again, agencies are working in silos and addressing the same population separately. So what this legislation aims to do is to establish this collaborative process across essentially 3 agencies. And that's the Department of Health, the agency where the Medicaid program is located, and then the agency where the state employee benefits plan is located. So that looks different in most states. Every state has Department of Health, but the other 2 are sort of in different agencies, and it's not the same in every state, but nonetheless, every state has those 3 entities. So what this legislation really aims to do is to establish a mechanism for these 3 agencies to come together to develop a plan that illustrates essentially 3 things. The first thing would be that really does bring their data that identifies cost and impact of diabetes on the population into one section of a plan. So what is the burden of the state from these 3 agencies' perspective? How much are we paying for this? What is our burden as far as numbers go? How much are we paying in employee health benefits for this condition? And really laying that out so that you can get a true understanding of what's happening in your state from these 3 agencies' perspectives. And then the next step is to say, okay, here's the problem, here's the burden, here's what's happening in our state. The next section is okay, what are you, each agency, doing about this problem currently? And documenting that, and even more so, are you doing anything collaboratively? So it really does give you a baseline for how it is that these state agencies are operating. And then the third thing is saying, okay, we've got this burden, we've got this problem, here's how we're currently addressing it. The next section is legislature. This is how we think we could do it better. And this is something that we could use your help with. So what the last section of the plan does is that it allows for an opportunity to provide recommendations that would result in some change. And some no-cost strategies. Cost strategies, just lay it all out there. What would it take for us to improve the problem? Improve this, and then we need to go back, implement that recommendation that the legislature might act on, and then we get to do it again in another 2 years. Let's keep doing this and evaluating this, because if we just do this once, you know, we just did it once and it's on the shelf. So this is a continuous process. Most states that we've worked, well, all states that we've worked with have embraced this because they don't typically get an opportunity to work with one another. And this provides that opportunity around a disease that is so prevalent and so costly. And it really does provide an opportunity to encompass all of what I said earlier around prevention, detection, and treatment into one plan. So we're seeing this play out. This is a really important step in the right direction to address the problem. Again, giving you a baseline and giving you more information so that you all could act and make some decisions based on the recommendations in the plan.